Alrighty, welcome everybody. Thank you for joining us. On behalf of the Florida Department of Health and Volusia County, welcome to the 2021 Path for Hope Virtual Summit. My name is Jordan Holly. I'll be facilitating this session. You have decided to join the session titled Partnership for ED Intervention. All participants will be muted during this session. There will be a question and answer time at the end of the session for you to pose any questions. You're able to raise your hand using the reactions button at the bottom of your screen. We will then call on you and allow yourself to unmute. You may also submit questions during the presentation in the chat box, and we will pose them to the presenters at the end of the session, if time allows. If you have requested CEUs for this session, please indicate your presence by responding to the pop-up poll in the middle of the session. Thank you to the Path for Hope Summit Planning Committee partners, Advent Health, Community Coalition Alliance, One Voice for Volusia, SMA Healthcare, and Volusia Recovery Alliance. It is my pleasure to introduce your presenters for this session, Geoffrey and Larry Brooks.
Well, thank you, Jordan, and we're so excited to have you join us today to hear about our partnership, SMA Healthcare's partnership with Halifax Health to provide intervention into the ED. I thought I'd start with an interview that Larry did a few weeks ago, actually a few months ago at this point, through Channel 6. They interviewed him for their Getting Results segment. So I think this is a good jumping off point for our presentation.
It's not working. I can't see it. Is the video playing for everyone? Because it's not playing on my end, Jeff.
I'm not seeing a video playing.
It's playing on my end. What are you getting, Larry? Just a black screen?
There's nothing but the link.
A suggestion from the audience is to make sure that you're sharing the screen that the video is on.
Why don't we skip the, I'll send a link to that for anyone that wants it. I had embedded the link and it worked when I tried it, so I don't know what the difficulty is at this point, but we'll move on. So what was the motivation that both Halifax and SMA Healthcare came up with in order to look at how we're going to respond to the increase in overdose deaths that were being experienced? And as you can see on this slide, what Halifax Health came up with is this increase between 2016 and 2018, which was really a 352% increase in the amount of overdoses that they were experiencing in the ED. And we coupled that with some statistics, national statistics, showing that 80% of individuals with an opioid use disorder are not receiving treatment. And then only 41.2% of treatment providers are able to provide medication treatment services through FDA-approved medications. And then we looked at the hospital and emergency departments being kind of an ideal place to intervene with people that are coming in that are kind of falling through the cracks. And the other strategy is really looking at peer intervention, and that being the key strategy that improves treatment for individuals and can be that intersection between emergency care and follow-up treatment. So what did the two partners being Halifax Health and SMA Healthcare, what did the two partners kind of bring to this relationship? And as you can see, Halifax brings 90 years of a history in Daytona Beach. They're a safety network, safety net organization. They have 3 hospitals and 3 ERs. They also have a level 2 trauma center and a level 3 NICU unit, and also inpatient, outpatient services, and they are a central receiving facility. So in a nutshell, what they brought was an emergency room and waiver providers. And then on the side of SMA Healthcare, we brought an agency that has 50 years of service within the community. Again, a safety net organization. We have outpatient and crisis services. We have substance abuse services, residential and justice services, along with a 24-hour, 7-day-a-week support hotline. So we brought to the partnership our peers and our MAT services. And now I'll turn it over to Larry to talk a little bit about the program, some of the eligibility requirements, and some of the unique features of what happens in the program.
Thank you, Jeff. Thanks everybody for being here that's listening and watching. And it's really great to be here to present some of this information to everyone. So first of all, the eligibility for the project when opioid overdose patients come into the emergency room, of course, non-fatal overdoses, from an opiate. They need to be administered Narcan, either by EMS or another service, or even, the ED by EMS. And most importantly, after they're entered into the emergency room, they need to sign a Halifax consent for HIPAA to talk with a peer, from SMA. That's very important for compliance with HIPAA to keep their PHI, protected. So that is the basic eligibility requirement, of the grant. And the peer intervention model that, that was come up with, for the emergency room, at least, get the patient stabilized from their overdose, present that patient with the opportunity and a brief description of, the opportunity to talk with a peer and perhaps get into treatment services with us at SMA. And again, gain that patient consent form. And once that patient, consents to talk with the peer, the physician will generate an order, for a peer consult, which comes to us, Geoffrey, myself, the Dr. Veal in Halifax and our access center here at SMA. A generic email is sent for, request for the consult. Upon, receipt of that consult order email, a peer will respond, and we connect and we contact either the emergency room physician who generated the order, or the unit clerk, or, the charge nurse, to get a little bit of information about that patient. We then, verify that the consent order was signed. And at that point, we are able to, establish and, conduct a conversation with the patient. It's kind of very important for us to, let these patients know that, as peer specialists, we are in recovery ourselves, so that we can meet them. You conduct that interview, and basically, lay out what the program consists of, being in the MAP program. The average response time for the peer specialist is less than 5 minutes, because from where SMA's MAP clinic is located, we're right behind the emergency room here at Willis Avenue. So the actual peer response time is within 10 minutes, no more than that. So upon the patient agreeing to services with us, we let that patient know that we will get them scheduled. We are able, right in the emergency room with our laptops, to schedule them in for an intake appointment into MAT, and schedule the provider appointment to begin their buprenorphine, with SMA. Upon those schedulings and appointments, we let the emergency room doctor know that they had those appointments, and then the ED doctor can then, write the prescription for that person to leave the hospital with a prescription for buprenorphine, Suboxone specifically, until they come to see our provider, so that they're not leaving the hospital, and being so withdrawal and being sick, and have to use something to keep from, entering into withdrawal and that sickness. And that is about, that's the access model, while, the peer is on call. Our 24-hour access model, it's basically the same exact format, except that when a peer is not, on shift or over the weekends, our 24/7 access center will handle those emails. They receive them all just like we do, but they know when a peer is on shift or not, and on the weekend. So the access center will contact the unit clerk, and they will do a teleconference with that patient. And just as a peer specialist, they will be able to schedule them for an intake and for a provider appointment to start the Suboxone and be enrolled into the MAP program here. Is there any questions about that? Okay. Well, the role of the physician, when we first started this program, we weren't too sure about anything, but we knew that this needed to be done. So what we have found over the course of the past 2 years with this project and this program, the role of the physician is really, to be educated, on the importance of MAT as an effective treatment for opioid use disorder. It's very important that we have physicians that are on board with this. And, to have a champion in an emergency room, wherever, this program or other programs may, start to be generated. Because with Dr. Veal in the emergency room at Halifax, I think without him as the champion for, this project to, connect SMA with Halifax, I don't think it would have ever been able to get off the ground. So that's very, very important to have, champions in your emergency rooms to be able to push for this to happen. Because there are a lot of different compliance issues and different agencies and funding sources, and that really needs to, be, a primary focus is to have somebody in your emergency rooms that are going to champion these projects. Another, implementation concern is, having ED physicians X waiver to be able to prescribe the buprenorphine. Dr. Veal had a lot of troubles, getting the ED physicians on board with that. But, over the past 2 years, we found that, a lot of the physicians, the APRNs, they are on board with this. And what we see for the role of the physician moving forward, I'm not a physician, but, in having conversations with them, it's having, the physicians aware that this project and these programs exist. And we want to try to be able to, have our peers cleared, to be able to consult with patients in all areas of the hospital, not just in the emergency room. We'd like to have, access to patients on all the inpatient floors, that present, with, co-occurring other, conditions, like endocarditis, or, severe abscesses that, need medical attention, but the underlying issue may be, substance use disorder. So, that's, something that we're looking forward, in the future to make that happen, within Halifax and SMA. The role of the peer, speaking for myself, it's to be an advocate and a cheerleader, and to be able to meet this particular patient population wherever they're at. We advocate for these patients. We help them to navigate through the system of treatment. Whatever we can do, within, the stipulations of our particular programs, we try to help these patients, and we let them know that, there's hope, they're not alone. Whatever we can do to help them along so that they're not alone. We always try to remove the idea of the stigma of the addicted person being, suffering from moral deficiency rather than a medical condition. And this is something that, is still, a problem, is the stigma of the addicted person. So we try in all interactions we have, whether within our organization here or with Halifax, we try to help remove that stigma. And that is our role primarily.
Well, thank you, Larry. As Larry mentioned, there were some unique challenges and some needs that we identified as we were implementing this program. And the first and probably the strongest need was to really have a champion within the hospital, to have somebody that was working in the ED that really saw the need of having some peers in the emergency room to really deal and talk with people that were coming in with overdose. And Dr. Veal, Stephen Veal, was really the champion at Halifax that saw the need in the hospital with returning people coming back and forth with multiple overdoses, and just really taking a look at that 352% increase that they were having, and came to us, SMA, with this idea of embedding peers within the hospital. And without that champion on the hospital side, this program would not be the success that it's at now, or at the level that we've since attained without that buy-in from somebody in the hospital. The other unique kind of characteristic or issues that needed to be worked out was when you're dealing with two highly regulated organizations, there are legal issues, compliance issues, funding issues, that we needed to work through in how to embed peers in a hospital, and what that meant for funding and regulation on the hospital side, and then what that meant for us on SMA side with our regulations and funding. The third kind of component to this that continues to be an issue is background screenings for the peers. It can be very difficult to go through DCF background screening for peers who come to us with that lived experience. And a lot of times that lived experience is some criminal justice issues, some charges that have been taken care of, some legal issues. So part of what we try to do is help peers that come in to navigate through that system and work on a waiver in order to be able to get waived for their DCF background screening. I was on a call a couple of weeks ago that DCF is kind of saying that they're speeding up that process, but it's still quite a complicated process to get through. The other issue that we are very mindful of and continue to be mindful of is putting peer support people into emergency rooms. Room. We started with 8 hours with him being in the emergency room and quickly discovered that having a peer sitting in the emergency room for 8 hours was not conducive to their recovery, just being in the milieu of what's going on in the emergency room, and not just with the overdoses, but all the other issues and problems that come in through the emergency room. So now we're fortunate with Halifax that we're right next door to Halifax. So our peers can spend some time here in the MAP program. And then when they get an alert, they can go over to the hospital and then spend some time in the hospital. So it really cuts down that need to have the peer in that environment. And we also are mindful of the peer's recovery and very mindful of people coming into the emergency room that may be people that peers know, have interacted with, or situations that are coming in that kind of hit them, hit home, and are situations where it's not conducive to their recovery. So we allow peers to determine if there's a situation where they're not comfortable, it's striking their recovery, to let me know, and we pull those peers out and get another peer to come in. So the bottom line is that we need to recognize and be supportive and sensitive to peers that are in recovery and bring that unique recovery situation to their task. The other kind of operational piece was just to come up with physician orders and alert system, teleconferencing. One of the unique features that SMA kind of brings to the table is our 24/7 access system, so that when peers are not on staff, we have somebody that responds, an alert comes in and our access staff responds to that client that has come into the emergency room. So there isn't a time during the day when somebody, either a peer live or an access person, cannot respond to somebody that's come into the emergency room. You know, the other unique feature is dealing with clients that are coming in that may not be ready for recovery. And that's really where the peers continue to remain in touch, maintain relationships. And some people leave the MAP program and are choosing to return to the MAP program. So we have people that come in, leave treatment, might come back. There have been a number of clients that will show up in the ED multiple times. And you never know when that time is that they're gonna, it's going to be right for them to come into recovery. So it's important to continue to have those conversations, to deal with clients as if that's the first time we've interacted with them, and really to have the peers have those lived experiences and, you know, try to convince them as much as they can to come into treatment. The other kind of obstacle with ED is how to induce people and to give them prescriptions. So there's a home induction that the physicians in the emergency room give to every client. and they're given a prescription that they can then fill that prescription and start on the medication before they can get into us for services. There's a connection between the case management staff over at the hospital and the pharmacy, and case management really help with making those connections between the pharmacy and the clients and getting their prescription. So there's great partnership between our peers and the case management staff over at Halifax to get people into our services and get them stabilized. One of the challenges we are finding at this point is due to COVID, there are a lot of traveling nurses and traveling doctors that are in and out of the ED. So it's just a constant reminder to us to continue that education and the challenge of continuing to educate nurses and doctors around the importance of getting people into services and treatment and looking at the unique needs that our population experiences as they're coming in and have dealt with overdoses. One of the unique challenges also is transportation, and part of that is a grant that we have from the West Volusia County Hospital Authority that allows us to have 2 part-time drivers and a vehicle that we can transport clients that live over on the west side of the county into their appointments here in Daytona, which has helped dramatically to get clients that are out in the underlying areas into services if transportation is a barrier for them to receive that service. Our peers can also provide transportation as a way to kind of look at that barrier. Some couple of other needs is data collection, always trying to come up with statistics and data and figuring out, are we having some success in what we're doing? Looking at the data from both Halifax Health and our data in the MAP program, and looking at where are there opportunities for some tweaks of what we're doing, where are we falling through the cracks, where can we implement different things that might be more successful to what we're doing. As all you probably know, it's one thing to come up with a program and write it down on paper and think that what you've come up with is a great idea. And when you start implementing, you might find areas that sounded great on paper that in the real world and real practice don't work. So we're constantly always tweaking, looking at different ways of doing things. And probably the last thing is just education, education, education. And that's an ongoing, everyday process, overcoming stigma in the emergency room with new staff that come in. As I was saying, with the traveling staff that are in and out of the hospital. It's just an ongoing process that Larry and his team are always trying to re-educate and work through that stigma and, get people to a place where, it's okay to provide assistance, and it's okay if people come into the emergency room 4, 5, 6 times, that it might be that 7th time when people get it and are ready for treatment. So what is our success rate? So we started this program in 2019. And in fiscal year 19-20, our success rate was 45%. So 88 people ended up in the ED, and we received, SMA Healthcare received intervention alert. And then 40 of those people actually ended up enrolling in the MAP program. And then in fiscal year 2021, we had 58 people that we got some sort of an interaction with, an alert. And then 60 of those people ended up in the MAP program for a success rate of that in that year of 38%. I will say that fiscal year 2021 was a year that was unique with COVID. There was a period of time when our peers were not embedded in the emergency room. They were responded telehealth, which we found was lowered some of our success rate in getting people into treatment. We discovered that having somebody in the emergency room, really sitting at the bedside, really having those conversations person to person was much more conducive to convincing people to come in. And so what is our current success rate for this current fiscal year, which started in July? So for July, we were at 29%. In August, we were at 30%. And then in September, we were at 33%. That's the percentage of people that we received an alert for, and then people that actually ended up in our MAP program. And if we look at those 3 months in a total, we're currently at a 29% effective rate. If any of you know success rates across the board for MAP program, for bridge programs, I should say, they're running anywhere between low 30s to mid 30s. So our overall success rates, if you look at the 2 first fiscal years and so far this fiscal year, we've been a little bit above the average. What are our continuing opportunities? Where can we look at both in our bridge program and the overall MAP program with SMA Healthcare? One of those things that we have just kind of started, we have a DART program. SMA Healthcare has a DART program, and that's currently run by our access team. And our peers have just started last couple of Fridays going out with the DART program, riding along with officers and EMS to follow up with people that they've interacted with overdoses. And that seems to be a great way of interacting with people in different ways, not necessarily people that have come into the emergency room through the EMS system, but might have come in on their own, where our peers can have interaction with them. So we're looking forward to continuing our partnership with our access programming and with Daytona Police Department in the DART program. One of the other places that we're looking at is expanding some of our services in Halifax Health to some of their other locations by having peers doing some telehealth, teleconferencing to expand that service to those 2 locations. So that if a person comes into those 2 hospital systems, they can still receive peer services through telehealth. The numbers in those 2 locations are at this point not high enough to justify having peers in the emergency room, but at least providing that service through telehealth. The other thing that we've done is we've moved this bridge program where it started with Halifax out to Advent Health, and have a partnership with Advent Health at this point to have peers similarly to Halifax embedded in their emergency rooms. Currently, we have 1 peer that's embedded in the emergency room at New Smyrna Beach. The unique function or feature of that peer in New Smyrna Beach is, as Larry was saying, the peer is not just in the emergency room, but that peer can go throughout the hospital. So if there's a patient that's been admitted to one of the floors with maybe an abscess or some underlying substance use disorder, that peer can interact with them in their hospital room, talk to them about services, talk to them about where they've been, that lived experience. So it's a greater interaction with the peers. And we're hoping at some point to expand that service at Halifax, which then will allow the peers to go up on the floors and have a more better interaction with clients, not just in the emergency room, but as they're interacting throughout the hospital, and especially those that have been admitted into the hospital. One of the other wonderful features that we've added to our program is Dr. Finley, who's our Director of Addiction Services, is now partnering with Halifax in their residency rotating program. So that as residents in Halifax are going through their rotation program, that our MAP program is part of that rotation program. So those residents spend some time in our MAP program here at SMA Healthcare with Dr. Finley, and really get a hands-on experience of what it is to be in a MAP program and what services we provide in the MAP program. And the goal and the hope is to take care of some of that stigma on the front end of people, of doctors coming into their profession. with that rotation and getting a better feel of what substance use disorder and services is all about and what a MAT program is. As I said, to kind of get rid of some of those stigmas that is part of what we all deal with every day. Another piece of what we're looking at is to expand our MAT services to other locations that SMA Healthcare has. Right now, our MAT service is primarily here in Daytona, but we're hoping to have MAT services in all of the other locations that SMA provides, so that we're providing MAT services to all the populations that we come in contact with. We also have a partnership with the Volusia County Jail, where we do some inductions for clients that are currently in jail, so that they can start some of the medication while they're in jail. So when they get out, they come to us for their services, and it's a seamless process of coming out of jail, already started on the medication, and then continuing with services, and hoping to have a better success rate of having people being seen in jail, started on the program, and then following up when they get when their time is done in jail. The other thing is we've expanded some of our medication to include Sublocade. We are doing that with insurance clients right now. Sublocade is a long-acting injectable similar to Vivitrol. But right now, it's both of those long-acting injectables are very expensive. We can spend some of our grant money on those, but it takes up a lot of our grant money. So right now, we're offering Sublocade to our insurance clients who can pay for that under their insurance, and seeing some success in clients that have not been successful in some of the other oral medications or Vivitrol. And seeing some success with that, adding that medication to our routine of what we're doing for services. So I want to conclude just with a kind of a plug for the peers that interact in this service. And I don't think that our MAP program or our Bridge program would be the success that it is without the peers. The peers, Larry as our lead peer, and Derek and Chantel and Bobby, who provide the peer services, are really a integral part of what we do here in the Bridge program and the MAP program in general. They bring that lived experience, that conversation that the rest of us who certainly have, compassion and understanding and hope, but they can have conversations of where they've been and what they've done. So I really want to shout out and a plug to our peers who are a fantastic piece of this program. And, without the Bridge program, we wouldn't be, and I gave you some success numbers and statistics, and those statistics and numbers are wonderful. But what I want you to see behind those numbers are really what matters, and that's changed lives, and lives that have actually been saved through this program, where before people were rotating in and out of the emergency room without any hope of getting into services. And now there's a peer there that can provide some hope and some guidance and some, a shoulder to lean on, and an experience that can help somebody make that change in their lives. And we call it a Bridge program, but I really call it a pathway to hope, that we're providing a way of people to become more hopeful in their situation and to move on with hope in their lives through their interaction with us and through the staff at Halifax and Advent to provide that bridge over to services. And again, I would just close with a shout out to the peers and what they bring to this program and to this process. And I will now open up to any questions that you have for either myself or Larry, and look forward to a dialogue.
Thank you so much, Geoffrey and Larry. At this time, you may raise your hand using the reactions button at the bottom of your screen if you have any questions. We will call on you and then allow you to unmute yourself. We'll also be alternating between the questions that were entered in the chat and the raised hands. The first question in the chat was from Todd Hawker. What is the average response time for the peer specialist to the ED? And you may have answered that, but I just want to make sure that it's read a second time because it was entered in the chat.
Sure. Larry, you want to tackle that one?
Yeah, since our location to Halifax is so close, when a peer is on shift, it's usually no more than 10 minutes before we are able to get into the emergency room.
If the peers are not on shift and the access is responding, we get an alert. So alert comes over through the email system, and the response time for access is minutes as well, as long as it takes to read that email and then click on the link and respond back to the emergency room. So it's a very quick turnaround time. With the peer that's in New Smyrna Beach, he's actually embedded in the hospital. So his response time is similar, mere moments just to get over to the emergency room. And again, we respond, the access center responds also to Advent Health when something comes in.
Another question from the chat from Nancy Rice. Sublocade isn't covered under SOR, is that correct?
It is covered under SOR. It is a very expensive medication. I think the current rate is about $1,500 a shot. We can use SOR funds for that, but it would take a lot of our funds to provide that. So we wanted to add Sublocade to our regimen of medication, but at this point, of the medication, but it is covered under SOR.
And then there was a response saying, thank you for clarifying. She had this question come up recently, very helpful.
Not a problem. Great question.
Are there any other questions? I'm not seeing anything in the chat or any hands raised. So I just want to say thank you, Geoffrey and Larry, for sharing your expertise today. Attendees, please make sure you use the link in the chat to complete the evaluation survey for this session. Thank you to the Florida State University for managing summit evaluations. If you requested any CEUs, you have to complete the survey to receive the CEUs. And again, thank you all for attending this session. Please go to your summit program PDF or visit thepathforhope.com/summit 2021 and click on the link for the next session you would like to attend. And I will now be ending the meeting for everybody. I hope you all have a great day. Thank you so much.